Um, but I now work full time with NHA, and I get to help others with their programs and kind of assist in that way. And I feel really honored to get to spend this time with you all today. We're going to talk about closing the theory to practice gap. It's one of my favorite topics, and I hope you all find it enjoyable and helpful to you today. So I am everybody, I'm jealous of you saying that you got good, nice weather and it's summer and sunny and what have you. It's stormy and rainy here. And so for bandwidth's sake, I'm going to go off camera to hopefully have a better connection and you all can see my presentation better in that way. And I hope everybody can see my slide okay, and we'll go ahead and get started. So closing the practice to theory gap is our challenge. Our students can master knowledge in the classroom, but they still stumble when it's time to apply and practice. Our goal today is going to be building stronger, more intentional bridges across this gap. And as you can see, safety experts say that the transition from practice to medical and clinical education is their number one patient safety concern. Here's what you'll walk away with today. You'll be able to recognize what the theory to practice gap really is and why it matters. Understand key reasons why this gap happens in the first place. You'll know why closing this gap isn't just ideal, it's essential both for patient success and learner success. You'll take away some strategies and resources to bring the clinical world into your classroom in ways that are practical and doable starting today. And finally, you'll have ideas of how to continue building competency through partnerships beyond the classroom into real life settings. So before we dive deeper, let's really get clear on what we mean when we say the classroom to practice gap. It's a space that's that disconnect between what students learn in the classroom and then what they're actually able to do once they go into clinicals. And it's not about pointing fingers at students, instructors, or programs. It's about rethinking how we design learning so that it connects more directly with what's real and to what matters most in practice. And if you guys will forgive me for a moment, I'm going to kind of change my screen here so I can hopefully see chat a little bit. Okay. So why does this happen in the first place? Our number one culprit really is infobesity. There's so much content to cover that students get overwhelmed. And it's not that any of the information isn't important, it's just too much to digest all at once. Next is the inability to ascertain what's really important. And so we cover everything with the same degree of relevance in mind and in time. Then, as much as we'd like to visit topics that we know for sure are really important, we've usually ran out of time. Textbooks, they tend to be heavy, traditional textbooks tend to be heavy on context and limited in content. Heavy on content, limited on context. Many of us teach the same way that we were taught, and I certainly did. But that dense textbooks requires a lot of memorization, and then the problem is we're left with little time to then situate the information to the actual care environment. Death by PowerPoint, we've all been here. 200, maybe even 300 slide PowerPoints, size 12 or smaller font, tiny graphics that are pixelated. It becomes overwhelming for the students and disengaging, even for those that really want to learn. Then there's the we've always done it this way mindset. And you can kind of think of this as going back and, teaching the way that we were taught. Change is hard, and especially when it's all that we know. But clinical care has evolved, also, so must our teaching. Then the one and done, it's not about rushing. Again, it's about volume. So much of the content is we have to get through that we barely have time just to even cover it once, let alone time to go back and do any repetition. But really, learners need introduction, exploration, reinforcement, and usually some remediation as opposed to just exposure. When we're crunched for time, as we all are, active learning often will fall off the table. We'll have every intention of doing some kind of really good activity, but we find that we've ran out of time when we have the opportunity to do that like we thought. Theory, poor linkage between theory and practice. Theory feels like school stuff, whereas practice feels like real world stuff. Unless we intentionally weave the two together, that gap only gets bigger. And then just because a student remembers something, like for our test, doesn't mean they truly understand it. And just because they understand it, then doesn't always mean that they are able to apply it when it matters. And we'll take a deeper dive and looking at some of these differences and talk about Bloom's taxonomy in a couple of slides forward from here. So I've arranged this in a format that we're all familiar with, risk versus benefits. When learning lacks relevance and depth, and they are unable to see its practical application, they then become unmotivated to continue to engage in learning outside of the classroom. On the flip side, when learning is relevant and enduring, it promotes that continuous lifelong learning and growth. They find that they actually like learning and studying. Secondly, risk include often a delay in delivery of care and the ability to respond quickly with rescue. And then sometimes care is inadequate when it is delivered, and it can even unfortunately lead to permanent disability and death. When learners are prepared for the clinical realities of healthcare, patients receive then timely quality care that saves lives. When there's a gap in understanding and the ability to perform at a beginning competent level, and I think sometimes we miss this point. I know I sure did when I first started teaching. We need to teach to the beginning competent level. There becomes a lack of trust and confidence, not only among their peers, employers, patients, public at large, but even they lack confidence, obviously, in themselves. And finally, this gap can affect not only the health of patients and the environments in which they're receiving that care, it also affects the health and well-being of the learner, the practitioner themselves. So we're going to explore 4 core strategies that you can use to build bridges. First, knowing levels of learning. We'll explore how application level really helps make content stick. Next, we'll explore knowing what's important. That's where prioritizing content based on real-world job tasks will come into play. Then connecting the classroom to the clinic. People think in stories and not just facts. When we teach through real-life scenarios, we help learners make that connection of information from the patient with patient care and what they'll actually be doing on the job. And finally, we'll explore providing the right content at the right time over time, not everything all at once, but in a way that supports retention, reinforcement, and readiness. So this is a very simple idea, and we've all heard this before. Hearing alone, it just doesn't stick. Seeing helps a little bit more, but doing, that's where real learning that can be used starts. And that's the heart of Bloom's, helping learners move from knowing to analyzing, applying, etc. Let's take a look at that. So let me get my pointer here. Bloom's taxonomy shows it starts and builds on top of one another. It starts at remembering and understanding to applying all the way up to creating new information. So students typically are going to start with memorizing and understanding, but to truly prepare, we need to get to this level of application and analysis. And I would say this is probably true of, you know, not just healthcare, any job that you're actually doing something. So the first level begins with simple memorization. And beside each one of these, I have included some verbs that characterize the learning behaviors that you're going to see with each of these categories. So these are things like define, duplicate, list, repeat. Then at understanding, the next level is can the learner explain concepts? And examples of that would be classify, describe, discuss, explain. And, when I think of this, I think of remembering would be structure, whereas number two, understanding would be function. So you would have, for example, anatomy and physiology. Then you have application. Can the learner use the information that they've received in a new way? Can they turn around then and apply it? Choose, demonstrate, dramatize, maybe even role play, interpret, etc. Then we have application. The fourth level is the learner's ability to distinguish between different parts, to compare and contrast. Not just list the differences, but know the differences. And that's why our bullseye here lands right between this application and analysis. That's the real sweet spot for healthcare education that we want to aim for. The next are evaluation and creating. And so I put some examples here with questions, and we'll explore them a little more in depth on my next slide here. But I'm going to use blood pressure, which is something really common that most healthcare workers need to know to do. First is, what is the normal range of blood pressure? So, they can memorize that. Systolic is, 100 to 140. Diastolic is 60 to 80. They probably change it. They always change that. But then, well, what does a blood pressure reading mean? Is it normal, within normal limits? Is it hypotensive? Is it hypertensive? Then demonstrate. We're at the application level. Demonstrate how to accurately obtain a manual blood pressure. Analysis, examine factors that influence whether a blood pressure reading is high, low, within normal range. Are we using the right side of blood pressure cuff, etc. Then evaluate if the blood pressure reading is valid. And finally, an example of build a resource to support patient self-care. So how would you help them know how to take the blood pressure themselves, for instance? So let's look at each one of those in a little more depth. I don't think we need to explain these first three, but let's look at analysis. And this is something that happens in practice. A patient has a blood pressure of 180 over 100. So what factors should you consider before taking the measurement or escalating care? This breakdowns this is comparing and contrasting. They know what normal is. Now we've gotten a high number, or what if we got a low number? What does that mean? And how should it inform our actions? Here's our next step of informing our actions. A student takes a blood pressure reading, it's 120 over 70. That's still normal, isn't it? But the patient says, that they're normally at a 98 over 60. So, how would you evaluate the accuracy of this reading and what should you do next? Well, it's within normal limits. Do you just chart it and move on? Um, this happens sometime. Or is this far enough apart from their normal that maybe we have something here? We need to retake that and, do something about this, inform someone. Good. So, then how do you take this information and prioritize what's important? If you've worked in the clinical setting, as I know most of you have, as an assistant, technician, nurse, therapist, you've had to make decisions around priority setting. 4 patients, one's ready for discharge, one needs a dressing change, one's short of breath, and another one's in pain. Who do you see first? And can you just decide not to see the others? How much time do you need to spend with each one? Well, they need follow up. Well, you need to bring in somebody else from the interdisciplinary team. You're not just guessing, you're prioritizing based on urgency, outcomes, and safety. And as educators, we face similar choices. Not every competency should be taught or practiced equally, nor should they be. So, how do you know where to focus? This is where certification test plans built on industry standards and job task analyses come in and can really help you make those type of decisions. So next, we'll take a high-level look at test plans to see how they can guide you in helping you make those decisions. You'll see not just the content area, what you have to, all that you have to cover, but how much weight is there for each one in real practice. So this is an example of our clinical medical assistant test plan, again, at a very high level. And you'll see the different percentages that people within industry say a beginning competent clinical medical assistant needs to know in their daily practice. So you can see over here, foundational content is 10%. You've got others that are 5, 8s, etc. But here you see that clearly the largest domain covers the hands-on care, direct clinical patient care. And this is things like assisting with vital signs, assisting with exams, supporting patients directly. And the test plans show us that what matters most is what they're doing most. So that's not to say that things like foundational knowledge and certainly A&P and administrative tasks as well should be neglected, but these are best going to be learned and understood through the lens of direct clinical care. For the patient care tech, you'll see that direct patient care is also the priority. The largest domain is helping patients with things like daily activities, monitoring conditions, ensuring safety. The test plan is going to guide us that supporting patients directly is what's going to be most important. Things like, again, the infection control, compliance, safety, they're essential, but they're best taught with patient-centered care as the foundation. Next, this is an administrative focus. And you'll see here that just like the clinical focused role, the biggest priority is tied to what they're really doing. So in this instance, the knowledge and task related to billing and coding is what takes center stage. The test plan is going to remind us again, real work drives what matters most. Our next sections are going to show you a lot of strategies you can use to connect the clinic to the classroom. But before we jump in, I want to give you a pro tip, and this will save you a lot of pain and heartache later is to always backwards plan first. When you begin, you need to, when you begin, start with the end in mind. This is going to help guide you in selecting the means to justify the end. Use the information that we, like the test plan domains and percentages, this is going to direct you to areas that on and let the real work guide your decisions. That way, when you engage in active learning anchored in relevance and real practice, you're not just covering content. And then finally, always ensure that when you engage in active learning in the class, homework, a project, even lab and clinical activity, that you're engaging in activities and asking formative questions that you're giving feedback to. And you want to always make sure that you take and that they see that again on a test. Otherwise, students will say, what was the purpose of doing X, Y, or Z? That didn't even help me on my test. And students are definitely going to see relevance in seeing it on the test again. And they're also more likely to engage in active learning in the future, not be disruptive and what have you, because they see value. So does this matter? Relevance is generally related to content that is believable, content that will affect patient outcomes, done frequently or urgently. And we need to make sure that we're teaching also the way we're testing. So, which of these relevance factors do you think lands more closely with your students? What do they respond more closely with? For some students, it's improving outcomes. Certainly, they don't want to cause harm, but for a lot of them, what is relevant is that it's something that they believe they'll really see in practice. Now that we've talked about the levels of learning and how to prioritize what matters most, let's talk about how we actually then bring this into our teaching. So, the first thing we're going to look at are two pillars that we can use for foundation, which is relevance and storytelling. This is also known as scenario-based learning. These strategies help your learners see meaning, build emotional connection, and ground knowledge in their professional identity. And that's what will transform simple information into something that sticks, transfers, and will shape their practice. So here's an exercise in relevance that I'm going to show you as an example that can be done as a ticket to class, or even you might use it as a warm-up activity at the beginning of class of like a think, pair, square, share activity. This comes from a professional responsibilities module, but again, you can use this with any module, any chapter. So have students refer to the learner objectives. And I'll tell you the honest truth, when I first started teaching, I didn't even know that learner objectives were something students should be able to know and do after they engage in the learning activity. I really thought that they were just topics. And the reason why I thought that is because that's the way that I was taught. But really, objectives are what should they be able to know and do after they engage in your learning activity. So have them look at the learner objectives and then answer questions in relation to relevance. So have them answer two examples how knowing information from these objectives that they can find within your learning activity, how would that improve patient health outcomes? Then how, if they didn't know something from this content, how could it potentially cause harm? What would need to be done frequently and what would need to be done urgently? And in this way, it gives students time to reflect on information before lecture. It will move your lecture time from introducing and memorizing content to clarifying, discussing, and applying information. It will also is going to give us insight and show us what's clear for them. How are they thinking right about this, or what is muddy and unclear to them that you can help them with? Most importantly, it's going to move your learners from recall to relevance. It helps them build a deeper understanding that would be practice ready. So here's an example of doing that. I took those same objectives and answered. I didn't give two examples, but I listed one example. So we all know we all know that if you did CPR, we would hope that it would improve outcomes. Frequently, they're frequently going to have to adhere to HIPAA. Potential harm if they didn't know it, or I'm sorry, I've got urgency here. They're not going to have time to go and look this up, are they? They may not have time to find anyone else to do it. They may need to do this. Potential harm, an example I put was medical terminology that if you didn't understand it well, could lead to errors, incorrect diagnosis and treatment. But certainly you guys can think of other examples, and so would your students. Improving outcomes, therapeutic communication. That's going to build trust with your patients, right? How about if they didn't adhere to HIPAA? We could put this over in potential harm, right? That could lead to identity theft, medical identity theft. It could place their places of employment at risk for a lawsuit potentially. Have to be done urgently. Observing chain of command. Hey, I need to report these lab levels that are critical here right away. So here's an example of a typical slide. I've certainly, arranged slides in this same manner, where here's an example of this is antihypertensive medications, recognizing and reporting adverse events. And, I could probably use any topic. This slide, it has all the right information. It's accurate. I could definitely do some test questions over this. It's even organized pretty decently, but would it be rememberable in a week or after they pass their test over this content? Would they even remember it? So this is what happens when we give content without story, urgency, or meaning. It's technically correct, but emotionally flat and cognitively forgettable. So I'm going to show an example of how you can take, you might call it an anchor case or a prototype. And you can do this with, any disease that you would want to do, or you can also do this with skills. It's a simplified representative example where you can guide your learners through what is most common. What are the most common diagnoses, most common treatments? And what you could do is you could have them do this as a flipped classroom activity. You could also do this as a group activity where you come up with a patient scenario and you could have one group answer these questions, one group answer that question, etc. And this is going to help them in distinguishing between that need to know, nice to know, and maybe even nuts to know. So here's an example where we've got a gentleman, he's 68. He's come in with reports of he's really tired, he's kind of dizzy, short of breath. And after reviewing the history, it includes that he's got a diagnosis of high blood pressure and he got started on metoprolol. The provider notes that he has bradycardia and his heart rate is at 45 beats per minute. So, greatest strengths, is this believable, you guys? I listed his greatest strengths as, well, he came to the doctor and he probably also adheres to his medical advice because he's probably been taking his blood pressure medicine. Um, Greatest concern, and you could come up with any scenario really that's typical. Greatest concern is that, hey, he might faint and he might have heart failure. It's obviously not working too well if it's only 45 beats per minute. Um, the heart beats blood that's full of oxygen. The rest of his organs may wind up not getting oxygen like they need. So, what are some early symptoms like headedness, confusion? Well, we don't know if he has confusion, so that might cause us to maybe we need to do further assessment. Most likely complication, he might faint, right? He's already dizzy. He's probably not getting enough blood. What are some risk factors here? Age, maybe high blood pressure, certain medications. Oh, it's a beta blocker. Look, does that end in an LOL? Most common diagnostics might have an EKG, might need blood work. So you guys see the example here. Now compare this to this. You can see how this is probably going to be more memorable than would be this. Additionally, this could lead into talking about many other things. Maybe, hey, if his heart rate's only 45, I wonder what his blood pressure's like. Hope this is resonating with folks. This is another example here of an anchor case, but from an administrative focus. Working as a billing and coding specialist, gentleman comes in, he has a routine exam. The doctor discovers he has high blood pressure and he puts him on some blood pressure medicine. So, how would you code the physical exam? What's the coding for high blood pressure for the diagnosis? And you could use this for somebody who's having to do both front office and back office task. Before we move on, we're going to talk about case studies, skills, and simulations. But I want to first share with you how our learning development and design team arranges modules to help bridge that theory to practice gap. They start with a module overview, which sets clear expectations, such as what was done with that objective activity. Then a patient experience coach comes in and connects that patient-centered care right from the start. They then have a framing case study, but much like our anchor case. Then they engage in the traditional skills, content, and immersion. Um, and along the way, they have little practice activities interspersed to, check for understanding, get feedback and rationale. And then they close it back up with going back and reviewing that information with the case study and then quiz to check for understanding. So case studies, they really can help, make learning real, situated to the actual environment. And this can be done even at the foundation and development levels. So here's an example here this is with the AMP heart and heart disease module. And you can see where there's lots of terms here, right? With myocardial infarction, ST segment elevation. So there's structures, there's function, there's treatment, diagnostics. And what they do is they have audio tools that will read this. But for me, I'm a visual learner, highlighted things that would be of benefit. Now, if I was really doing this myself to really learn, I would have selected different colors and probably done like, all of the structures one color, all of the treatment one color, all of the meds one color, etc. But they also allow them the capability to make notes and bookmark content that they can go back and check. So offering those different modalities really is of help. So next we're going to talk about simulation. And simulation gives our learners something deeper than just practice. It gives them permission to not get everything perfect the first time. And it builds that competence, confidence, and lifelong learning mindset. Anytime you're learning something, you're not going to be perfect, right? It really gives them that learning mindset. So simulation gives learners that space to apply what they've learned before they've ever even seen a real patient. It's where they can make decisions, communicate, and even make those mistakes that keep you moving forward, learning and growth. And it helps connect those hard skills like vital signs and soft skills. And really, I wish that we'd all decide to rebrand soft skills and start calling them crucial skills because, really, they save lives. We've all, seen it where or maybe this has happened. It's happened to all of us, being a new medical assistant, a new patient care tech. Um, Maybe they take a blood pressure reading and it's low, but they hesitate to escalate. Nervous about bothering someone that's higher up. Maybe they're even unsure of the accuracy based on their skill set and they're too embarrassed to ask for help. And that moment of hesitation can really delay critical care. And simulation is going to help them with that cognitive rehearsal of asking for help in dealing with difficult situations. That's going to help protect, patient safety. So up next, I hope, make sure that my settings are correct here. I hope that I can share my audio and you all can let me know if you can hear. So sorry and thank you for your patience. Contra, I can see you. Can you still see the screen here?
Yeah, I can see your screen, but there's no sound. Like if you're trying
Okay.
to turn the sound on, I can't hear anything, but we can see the screen. I can see the screen.
Could you hear it then?
No, you can
Okay.
see the simulation. You can see the
Sure.
movement on the screen, but no sound.
Well, gosh, I wish I could share this because this patient is really kind of argumentative. And it's the kind of stuff that they encounter. But anyway, this. They go through the patient's upset. They've gotten a shot and they have to wait 20 minutes to see if they have any reaction from the shot. And apparently they weren't having to do that in the past. They need to get back to work and what have you. So they get options to make decisions and how they respond. And I'll tell you, sometimes I bring this up in class and we make these decisions together and see how it goes. And sometimes I'll even know that my students are wrong and I'll go ahead and do it so that they can see, well, then what is the result from that? And then we have further, deeper conversation about that. So now I'm going to move to skills. And skills are, that's competency in action. And skills demonstrations plus those checklists really ensure consistency and competency verification. And often what I do is I have my students observe the skill and I'll go ahead and play this. I know the sound's not working, but I have them check it because it goes step by step with the video. I have them watch the video and then check it off. Now, could they just go in and just simply check that, turn that into me? They can, but it's an attestation that, hey, you've looked at this, and when you come to this, you're coming to class prepared. And I'm going to naturally expect that you're going to have some help with applying the cuff and adjusting and manipulating the gauge and things like that. But this is not the first time that you've seen this, right? And sometimes I watch this with my students, with the video, and then I'll stop it intermittently when there's, critical points here that I want to talk about. For instance, this says, you know, place your stethoscope firmly over the brachial artery without depressing the artery. So, well, what would happen if you did do that? Well, number one, you probably wouldn't hear it, right? Um, Also, why do we pump it up 30 degrees higher than their last reading? Why is this important? So in this space, you can talk about that oscillatory gap. And then, what to deflate it at a rate of 2 to 3 millimeters of mercury per second. To give your ears time to hear, I don't know about you all, but most of the time, my students, and this is a difficult skill to learn, is they're not doing it wrong, they're releasing too quickly. That's the biggest thing that they usually have to have help with. So then this is a feature that we have with our tools that provides real-time coaching as the learners practice clinical and administrative skills. But it helps move the students from being task-oriented to person-oriented. And it helps them see, not just getting through the skill, but how does the patient feel throughout this visit? And a way that you can do this in class is have a guest speaker share their personal health journey. And it's a way to hear the course content and connect learners to lived experiences. So you can see the questions here, and you can even build, on top of this. And it helps them get used to talking to people, covers important clinical milestones like family history and diagnostics, but it helps them in sharpening their ability to listen and ask relevant follow-up questions. And then from here, you could have group discussions, written reflection, etc. But I will recommend always use a patient with a common diagnosis. That way, they are communicating with patients and their lived experiences that they're most likely to encounter. Other diagnoses might be interesting. I promise you, you'll have people who are going to come up and go, I know somebody who had a, a heart transplant and a double lung transplant. Oh, they'd be so cool to listen to. But if they're not likely to ever encounter that in practice as a beginning competent, you know, whomever you're trying to train, then you may lose valuable classroom time that you're then not able to recover. So now I want to talk about something here. If you had the choice between this or that, which one of these would be more easy to consume and enjoyable to eat and also remember, especially if your granny made it, right? The same is true of our learners. When we give information that is isolated, like terminology here, A&P here, classroom here, lab here. I'm going to say lab here because it's mini chocolate chips and they like doing labs. Often it's like handing them raw ingredients and expecting that they know how it would all fit together. When we layer content and integrate it with this, then that's going to be like baking our cake. The flavors are going to connect and make sense and also stick to them. So next we'll take a look at pacing and layering content so that students can consume that information, use it, and remember it. So this is an example. We're going to talk about that right content at the right time over time. And this is an example of concepts-based arrangement. And this is where, if you're teaching the integumentary system, why not a skill that they would see at the bedside? We all know that with infection control, our first line of defense is going to be skin, right? The most important thing we can do to prevent the spread of disease is going to be hand washing. From there, you can move from simple to complex. So they've learned how to be safe. Now let's learn how to communicate. They learned integumentary system. Now let's do skeletal and muscular. Then, now that they've been introduced to this terminology and the skill that all healthcare workers need to know how to do, let's then have our opportunity to go back and revisit this when we're doing more advanced skills. We're going to do a deeper dive with A&P and Patho when we're doing those more advanced skills. If they made a 70, we can go back to that 30% that they didn't get correct and revisit this, right? And have a deeper understanding. Also, if they're doing clinicals at this time, you may ask them, at your clinic, you may ask them to gather this. At your clinic, what were the top 3 integumentary disease processes? Not every single one, but what are the top 3? And they may have difficulty, getting things like top 3 risk factors, early symptoms directly from the clinic. They might have to look that up. But what were the most common tests that were ordered at your clinic? What were the top 3 medications that were prescribed? What were the most common treatments? So here's another example of this with the cardiorespiratory systems. So introduce, most healthcare workers need to be doing vital signs. Introduce your med term with vital signs. When you go to do more advanced skills, then do like EKG, then do your deeper dive with A&P during that time. You also might intentionally work in with your skills round robins where you're going back every 1 weeks and revisiting those skills. Also, if you have students who maybe they're taking med term and A&P, like their sophomore and junior year, and you've got students who are doing their clinical, their capstone courses in their senior year, maybe have these students come in to be the ones that, they're practicing the vital signs on. Well, now we'll talk about learning beyond the classroom. So whether it's
Kelly,
work-based,
Kelly, I
yes.
should probably give you have a like a 4 minute warning.
Oh, okay, okay. So we can wrap things up. This actually is the end,
Okay.
but
I just
and
wanted to make sure.
thank you for letting me know. These are some examples of forming partnerships after they're learning with you. And just most importantly, I was going to close with just between knowing, doing, and caring, you guys really, you are the bridge. That's why they have you teaching this. This is why you went into it. So I hope this has been a benefit to you all, and I've enjoyed meeting with you, and I hope it will help you.
Kelly,